Hi everyone, my name is Fiona Young and I am the Marketing Manager here at Flen Health. Firstly, I'd like to say thank you very much for joining us this evening for our Diabetic Foot Ulcer in Practice webinar with the lovely Alison Musgrove. So Alison is an Advanced Podiatrist in Diabetes and Research and has over 25 years experience working in foot clinics. I will introduce you to Alison very soon, but before I do so, I would just like to talk briefly about your attendance certificates, which I'm sure you will all be wanting to receive. So if you did register via an email link, then you really don't need to do anything. You will automatically receive your attendance certificate through to your email that you registered with. If you are watching us this evening through a link that was sent to you via a friend or a colleague, then please just complete the registration link that you will find in the messages at the end of the session or during the session, and we will make sure that you also receive your attendance certificate. We would very much welcome questions. Alison's going to be on hand throughout the whole presentation. At the end, there will be a Q&A session, and when Johnny's presenting, there'll be a Q&A session. So please don't be shy. Post a question in the messages, and Alison and Johnny will answer as many as possible. So after Alison's presentation, Johnny Boyne, who is an RBM at Flen Health, he's been with us for 5 years now, is going to be given a short product presentation basically on the use of Flaminal in general practice. He's then going to cover the use of Flaminal within diabetic foot ulcers, diabetic foot packs, and also just general use of Flaminal. So without further ado, I would like to hand you over to Alison Musgrove.
Hello everybody. As Fiona's kindly introduced me, I'll just reiterate what she said. I'm Alison Musgrove. I'm an Advanced Podiatrist in Diabetes working in Nottingham. It's really kind of Flen Health to put this on tonight so that we can reach so many people with some quite important messages about diabetes and feet. I'm sure for a lot of you this will be a revision exercise. It'll be things you've heard before, it'll be an update perhaps, but also it will give you a chance to ask questions, and I'll do my very best to answer them. I work in Nottingham, and it's a very busy multidisciplinary clinic that I'm involved in 5 days a week. We see up to 130 people a week in that clinic, and we deal with foot disorders associated with diabetes. Now, I've been asked tonight to update you on diabetes and foot ulceration, but I'm also going to add in a little bit about other complications in diabetes, if you don't mind. I'm sure, like many, you've all heard the figures on diabetes and foot ulceration. It's an expensive disease. It carries a lot of morbidity and mortality. And with 4 million people in the UK diagnosed with diabetes, approximately, and it's growing, this problem is only going to get worse. This last year, we've definitely in our area seen a lot more hospitalisation and amputation related to diabetic foot disease, and we're looking into the reasons for this. Now we have that data, but I suspect a large part of it will be people who have just stayed away from hospitals and even healthcare professionals generally, either due to fear or misinformation that clinics weren't running. I can assure you that all diabetes foot clinics have run right the way through this pandemic, but it has increased the rates of complications going beyond the care of healthcare professionals such as us and leading to amputation. In line with this, in Nottingham, we've seen a lot more shared care in conjunction with specialist clinics. This has been enabled by digital technology, and it's shared care with people like yourselves, practicing nurses, district nurses, and patients and carers themselves. But foot ulcers, their causes, their factors that go to making them hard to heal, and the guidelines and recommendations about their management and assessment haven't changed. Now, I say that a foot ulcer should be referred within 1 working day to a multidisciplinary foot care service or foot protection team. Now, I know that across the UK and in other countries indeed, everybody has different referral criteria in their locality. They refer differently. There are different referral routes. And if only that weren't so, I think a lot of problems could be sorted out far more easily. Why a multidisciplinary foot care service? Well, this diagram kind of shows what a typical multidisciplinary team looks like, who it's comprised of and why. The multiple pathophysiological mechanisms that go into not only obtaining a foot ulcer, but also in the delay of its healing can be seen around the inside. And it becomes quite clear why you need the people around the outside to heal this, whether it be external or internal problems. However, what we are seeing is that only in the UK, fewer than 40% of people are referred within the NICE recommended time frame of 1 working day. And this is through a national diabetes foot audit where all specialist centres that care for diabetic feet input data onto new referrals and how long it's taken for somebody when they first presented with a foot ulcer to get into the specialist team. And this is actually linked, I don't know if you can see here in this diagram, this is linked for the first time to this first expert assessment by specialists as a prediction to being alive and ulcer free 6 months on. And the sizes of the circle relate to how much that impacts on to somebody being not alive and not ulcer free at 6 months. And you can see time to first expert assessment is quite high up there. So with this in mind, Flen Health came up with the idea to produce the Diabetic Foot Rescue Pack. And this was based on an acronym that myself, Wendy Walker and Paul Chadwick, all specialists in diabetic foot disease across the UK, came up with. And along with Flen Health, we managed to put it into a leaflet that's being distributed in packs of Flaminal to practice nurses. Now, as we came up with it, I thought I'd use this as the basis for the presentation tonight. The acronym itself is here, and I'm sure that Fiona will provide you with a link to the article because it has been published if that's what you'd like to read. So I'll begin at the beginning with the P, presentation. We all know that they present in many shapes, sizes, formats, causes, smells, looks. What I didn't put was that they present on a Friday afternoon late when you could well do without it, but I don't think we can solve that problem. And the first thing we have to do is assess this wound. So the description of it, where is it? What does it look like? What does the skin around it look like? How long has it been there? This, as we'll come on to see later, can be a bit more of a problem, but we'll try our best to ascertain the cause of it. The assessment will also include looking at the person themselves. Are they able to care for themselves? Do they have a carer? Has this gone unnoticed for some time? That can be a good indication if they live on their own that perhaps it has, particularly if it's underneath the foot where we all don't tend to look on a daily basis. Some causes are easier than others to diagnose. I'm sure that if somebody presented with this, you'd have no problem in diagnosing where the hole and what caused it was, but others take a bit more investigations, and again we'll come on to that later. Now, if somebody comes in with this sort of presentation of a wound with no sign of pain, it's pretty obvious that they've got neuropathy. So this is the damage to the nerve endings that's done through high blood sugar levels. The nerve endings basically in the long nerves further away from the spinal cord die first. So peripheral diabetic neuropathy is always distal. It's always at the longer nerve endings first. I don't know how long people on this chat have been practicing for, but I know when I started that they were using this monofilament test, which I'm sure you'll all have heard of. I'll come on to describe it in a bit more detail. We were using it on 10 sites on each foot and doing it twice at each of those sites. Thankfully now, because of studies that have been done, we only need to do it between 3 and 5 sites, bearing in mind, like I say, the nerve damage is distal. So if you can't feel it in your forefoot, or somebody can't feel the monofilament at the toe and forefoot, then there's no point doing it anywhere else. They can't feel it, they've got neuropathy. You may know this test better, not when you're presented with an ulcer perhaps, but in the annual reviews that people undergo for their feet. It's a simple test and it's a bedside test. When I say simple, I have seen the monofilament test done very poorly. I'll admit, not by nurses, generally by doctors, where somebody actually strokes the bottom of the foot with the monofilament. Unfortunately, the stroking effect does not stimulate the fibres that we want to stimulate. We want to know if somebody's got loss of protective sensation. But believe me, that somebody coming in with this, if you stroked the monofilament up their foot, they would leap on the ceiling. They could actually feel it. So you're not really gaining anything from doing that. So when you're testing these sites, the monofilament bends on the foot, but it mustn't slip or wobble or jump. And if it does, that's a negative test. Don't count that one and do the area again. A couple more tips from bitter personal experience. Don't ask a person if they can feel this when you touch them. We all like to please people, and generally people will say, yes, I can feel it, and it confuses the matter. Ask them to look away, and then ask them to tell you where and when they can feel you touching their foot. For example, they might say left foot on the toe, you're nowhere near them. You're gaining some indication as to whether they can feel it or not. You might be pushing the monofilament against the 5th metatarsal head and they're saying nothing. That's ideal. Don't then ask them, can you feel this? I think that the neuropathic testing is probably a lot easier than the other biggie that causes diabetes foot disease, which is peripheral arterial disease. It's very common in people with diabetes. The blood vessels become blocked much younger. They become blocked at a lower level, which makes them even harder to revascularize. They're not as amenable to angioplasties, more likely to have a bypass, and the diagnosis of it is actually very difficult. I've put this slide up just to show you how difficult it is, because even the experts internationally can't agree what clinical examination done at a bedside can reliably exclude peripheral arterial disease. I think it's becoming more and more obvious that there actually isn't one. However, we all have our fingers, and in an assessment, it's vital to try and take the pulses of a person's foot. So the dorsalis pedis pulse, the one on the top of the foot, and the one behind the ankle bone on the inner point of the foot. Now, if you can feel these, great, because if they're palpable, then it's very unlikely that somebody's got peripheral arterial disease that requires immediate urgent attention. But having said that, we all know that our patients don't have feet nice and slim like this. They tend to come in with a bit of edema, a bit of swelling, maybe even some compression bandaging on, and it's very difficult to feel the pulses. Not being able to feel them doesn't mean that there is a great issue. However, discuss with your local specialists what sort of pulse palpation they'd like noted in the referral, or if they'd like any other tests doing. We've not all got this Doppler that you can see in the left-hand picture at the bottom there. If you have got it, great, use it. Depending on your time and skill level, it can be useful to listen to the pulse waves, whether they're monophasic, biphasic or triphasic. I can't do many impressions, however I can do a great impression of a Doppler sound. When somebody has triphasic good pulses, what you'll hear is, if it's biphasic, you'll hear. What you don't want to hear is monophasic. Thank you. The Dopplers are useful adjunct, but as I say, the main thing is if you're presented with a diabetes foot ulcer, palpate the pulses, just check to see if they're palpable and note that in the referral. There are exceptions, of course, to every rule. Here we can see that there are clues that the main circulation, the main blood vessels are patent and open. Can you see the hairs on the dorsum of the foot there? We can see that the skin is shiny, tight and taut, meaning that blood's getting there. But what's happened here is that this swelling from an infection that's got in through a portal, perhaps in between the toes or underneath the foot, has actually caused, this swelling has caused those local blood vessels to occlude. And so what you're starting to get is necrosis in the big toe here. These tissues are starting to die, but I really don't think it takes any fancy equipment to tell you that that is an emergency and needs either A&E or one-stop clinic, depending again on the access in your area. Probably for intravenous antibiotics immediately. Another point that I always make when people are assessing feet is to look at both feet together. It's very important because unless you look at them both, you don't know if one's normal or abnormal for somebody, and it can give great clues as to what's going on in one foot rather than the other. On the left picture there, it's a rather subtle difference in colour, but you can still see it, and on the right there's a very distinct difference. This also goes for feeling the feet, for temperatures. Our hands are very sensitive to temperature differences, but only when they're done at the same time. So you'd be feeling one foot in the same place as you were feeling the other to gain some appreciation if there was temperature differences in the feet. So, like I said, speak to your local team, find out what information they'd like about a person's assessment. We've already seen the importance of early specialist referral, and as I say, different centres have different referral routes. And in Nottingham, we fought long and hard to be able to get people to, all healthcare professionals to be able to refer in, not just GPs, and that's worked very well. I'd really like to see people who've had foot ulcers being able to refer themselves in. It happens in some areas, but in our area at the moment it's deemed what you'd call a step too far, but we'll keep on with that. So we come to my kind of favourite area of diabetes foot ulceration. That is solving what has happened to the foot. As I say, not an easy task when somebody can't feel what's going on, and the first time that they're aware anything is wrong is when their wife's behind them screaming at them because they're trailing blood along the carpet because they've got a hole in the bottom of their foot. Pain's a gift. If we don't have that pain, we can't avoid the things that have happened or know that anything's going wrong until it's too late. Often in diabetes, it's the shoes, the footwear that have caused the problem. So somebody will buy a new pair of shoes, they won't realise that there's a seam in there that's rubbing their toes, they'll carry on walking in it because they're not getting that pain sensation. I had a lady once who went out and bought a pair of trainers They're ideal footwear. They've got a lace, they've got a cushioned sole, and they're generally quite wide. And she decided, because the footwear she was wearing, we'd recommended her not to wear, she decided to wear those to go shopping in. Unfortunately broke every single metatarsal bone in her both feet because she didn't take the tissue paper out of the end of the trainer, and she couldn't feel it. That's how dense neuropathy gets. So you can imagine some of these minor scrapes and cracks, like on that left-hand picture, really do go unnoticed very quickly. What I would say is, if you can come to a compromise with somebody about getting the pressure off that area, so if the shoes that they're wearing when they come in have caused it, can you talk to them about having alternative footwear just to get them by, just to take the pressure off until they can be seen by a specialist to give temporary shoes or orthotic footwear? That's ideal. Then they're not going to be happy about cutting a hole in a shoe or a slipper, especially not if they've just bought it, but it comes down to saving the foot as much as possible. Along with this, very commonly in diabetes, you'll see these foot deformities which go unnoticed. They're quite insidious in their onset. So what happens is, as the nerves die in the foot, the intrinsic muscles, and there aren't many of them, the muscles that actually originate and end in the foot, but as they die off, they actually cause the toes to claw. So the toes claw back and the arch becomes very high, and there's two problems there. The toes clawing mean that shoes that once fitted don't anymore, and they rub, the tops of them are rubbed very quickly. But also you can see here, you get these very high pressure points under the foot, particularly under the first metatarsal head, where it hits the ground first, because what also happens in diabetes is that tendons get thickened and shorten, and so the tendo Achilles area doesn't stretch as much out the way, so the foot's pointed down. So you get this very high pressure point at the first metatarsal. Add on to this again the fact that people who get neuropathy tend to be taller people first. They tend to be men, they tend to be heavier, and they also don't know when their foot has contacted the floor like you or I would, because they can't feel their foot when it first touches the floor. The only way they can feel it is when they get the vibration up their leg. And to do that, they have to do a very heavy gait, a very heavy footstep. All those combined are a perfect storm to these first metatarsal head ulcers. The skin cannot stand this repeated trauma, and it breaks down. And these are just some of the ways that foot ulcers can occur. Of course, not all of them are quite as obvious as that. I've got some examples here of people who've been through our clinic in the past couple of years, as to how we have to use detective skills, just like you do, to be able to diagnose how something happened in order to prevent it happening again. So this first chap, he'd had his foot dressed, I believe the ulcer was underneath his foot, and he decided that he wanted a bath. Now we recommend, obviously, like you would, not to get these dressings wet, so he did the usual and taped a carrier bag on his foot with duct tape. Unfortunately, it was one of the safety ones that had holes in the bottom of it, and so the water leaked in and his dressing got dry. What do you do with a wet dressing? Well, you dry it. Unfortunately, he used a hairdryer to do so and could not feel the heat from it and caused a very nasty burn, as you can see there. The next chap came in. Actually, it was both his feet were like this, and a lot worse than this when he first came in. Blistered underneath the underneath of the foot and the toes. He'd no idea, as most people would say with neuropathy, well, I just woke up and they were like this. it took a lot of questioning to find out that he'd recently been to see his sister in London, and she just moved into a new apartment. And when I asked him if the apartment had underfloor heating, he said yes, it did. And this is what had actually caused these burns. Now, underfloor heating to you and I would not cause burning. It wasn't on particularly high, no one else in the family got them, but because people with neuropathy, their dissipation of heat through the nerves is disrupted, the heat stays very localized. Also, what happens with neuropathy is people stay very still. So you and I are making micro movements with our feet all the time without even knowing it. People with neuropathy don't do that, so their foot stays very flat, and again the heat can't escape. Similar to the next chap who took his wife for their anniversary to quite a posh spa hotel and didn't actually read the signs on the warning signs on the spa steam room, which said do not sit near the steam vent, and he promptly did sit near the steam vent, and while they were getting nice and warm and toasty, so were his feet. Unfortunately, this steam caused massive burns to his foot, and he eventually did actually lose that big toe. Not being able to feel your feet is a massive, massive issue. I like to refer to a chap that I used to see a lot, and he used to tell me that he treated his feet like pets. Now, pets can't tell you when something's going wrong with them, so you have to keep a very close eye on them, and that was what he liked to tell me he did, and he did. So it's very important when you're doing the monofilament tests, when you're asking someone about sensation, it's very important that you relay to them what the test results are. So if they have lack of feeling at one spot, explain that you know they may get problems and not feel them, and that just because something doesn't hurt, it doesn't mean to say that it's not an issue and they shouldn't report it. If I may now just move away from diabetes and foot ulceration and come to something called Charcot foot, something that I'm sure you've all heard of, and you've probably all seen it, or a lot of you have seen it in a form that is actually when it's when the damage has been done and when it's quiesced, and when the problem is now not acute anymore. However, it's very, very important to catch it before that, and I'll just run through some of the signs of this relatively rare condition, although we don't think it's rare because we see quite a lot of them. Relatively rare but devastating condition that can lead quite quickly to amputation if it's not picked up. We don't know why some people with neuropathy get this problem and some don't. It always happens to people with neuropathy. It never happens to people without it, and at first sign of it, it involves just one foot, as you can see here, and leg swelling. It's usually warmer in that swollen foot, and again this is where your comparison comes in, looking at both feet, feeling both feet at the same time for the temperature difference. Sometimes it will be red, sometimes not, and about a third of people remember some form of unusual trauma, be it a slip, trip, fall, exercise that they've done that they wouldn't normally do, particularly walking up and down hills. And they may have actually heard a crack in their foot, and it may be painful in a foot that would otherwise have no sensation in it. What happens is in this disorder is that the inflammatory response seems to go haywire. So the osteoblasts that are building up bone all the time in all of us, and the osteoclasts break it down, the osteoblasts build it up, the osteoblasts in this condition kind of go to sleep, and the osteoclasts that break bone down go on a holiday, and the breaking down causes the bone to soften. Obviously it's in a foot, you're walking on it, bone has to be strong to be able to support your body weight, and this is the sort of ultimate disaster that can occur if Charcot foot isn't spotted early. The bones literally can explode. This chap came to us after a year of being treated for various things: infection, lymphedema, DVT. He was treated for gout, suspected osteoarthritis, fracture, although nobody x-rayed his foot. And all these things are important to consider in your differential diagnosis. However, if people, healthcare professionals who patients first present to, don't have a high suspicion of index for this disease, they're never going to pick it up, and it will continue to become devastating. That this led to an amputation because this ulcer underneath the foot, where the bone had protruded, cannot heal. There was no way we could get a shoe on it. It became infected, and once you get infection in the bone here, there's very little likelihood of it having a good outcome. So just bear in mind that if you're getting people with these symptoms, have Charcot in your mind, because you'll be a hero if you diagnose it, but no one will blame you if you actually think it is and it isn't. I wouldn't worry about that. So moving on from these sort of diabetes foot ulcers and Charcot, going back to pass it on, we can. Oh no, I'm sorry, I missed this. Offloading. So something like this, if we catch it early, we can cast it and offload it. The foot ulcers that you've seen in the previous slides can be offloaded. This is the main difference between foot ulceration and something like a leg ulcer. Feet, people still need to be mobilising on. They still need to be able to walk around, get around, albeit we ask them to minimally weight bear while they've got problems. People have to live, and confining somebody to a wheelchair is perhaps not an ideal treatment for both them and for their condition generally. And so in specialist clinics, we'll work closely with orthotists, plaster nurses. We'll have a range of temporary footwear that perhaps isn't available in primary care, or with the goal of offloading ulceration, and then once it's healed, keeping it healed by protecting the foot, both on the top and underneath. Now, getting people to wear this is a whole other topic that could take up another hour or 10. So we'll leave that for another time. So coming on to infection and treatment. Infection is a massive issue in diabetes foot ulcers for a number of reasons. The wounds are there for a long time, so there's more chance of them becoming infected. Feet are difficult to keep clean at the best of times. When a break in the skin occurs, it occurs very close to bone as well, so you've got a huge and real risk of osteomyelitis, which involves far longer treatment and quite often surgery to heal it. I think soft tissue infections are a big issue, and 80% of amputations are preceded by infection. So this is a major cause of people losing their lower limbs or bits of them or toes. Every time somebody even loses a toe in diabetes, it can be a disaster waiting to happen, because you don't just lose that toe, but you lose the proper architecture of the foot, which can then lead to transfer ulcers, and these work their way along. And so treating infection adequately but also appropriately is a big thing in diabetes and foot diseases. I'm sure you're all well aware. We in our clinics and many diabetes specialist clinics don't swab wounds. a swab won't generally tell you which organism is infecting it, because the swab only holds on to those microbes that can live long enough to get to the lab, which tends to be the strong ones. If you want to know if a foot is infected, by the time you've sent the swab off and got it back telling you that it may be, you know, things could have gone too far by then. So what we do say is we look for signs and symptoms of inflammation. Now, warmth and redness are fine in somebody who's got just neuropathy, but in somebody who's got peripheral arterial disease, to any extent, these can be masked. Tenderness and pain, we've already know that people can't feel their feet, and so it tends to be just experience and signs and symptoms and the possibility of it being infected. Of course, we don't want to over-treat infection with antibiotics because of antimicrobial resistance, and I'll come on to that in a second. But having adequate antibiotic cover if you're concerned about infection is vital. We generally tend to treat soft tissue infections by these guidelines. So using the most likely infecting pathogen, which in the UK is probably Staph aureus. Perhaps you have known local resistance patterns, which you would have to take into account. You'll have local guidelines for this, and you also have to consider if the drug can be actively delivered to the site by oral antibiotic choice. Is somebody so vascularly compromised that they might need intravenous antibiotics or vascular intervention to get those antibiotics there in the first place? Generally, as a rule of thumb, if somebody isn't to penicillin allergic and it's their first set of antibiotics, we would generally go for flucloxacillin 1 milligrams QDS. But please check with your local microbiologist and microbiology team as to what they would suggest. And as I've mentioned already, topical antimicrobials are becoming more used, and this is due to the increase in antimicrobial resistance. So there is far more thought now put into what antibiotics people go on for, how long and when. Obviously, wounds can become colonised, and that's usually the case before they become infected. So reducing bacterial bioburden or biofilm when it's in a wound, and particularly chronic wounds, is very important. It doesn't matter what dressing you put over a wound, what dressing type you use, if it doesn't get rid of the biofilm in the first place. So these biofilms, not necessarily, they're not visible, but they stop neutrophils coming to the surface. There's some very good webinars on it at the moment that have been recorded on the internet. If you want to look at those, they're excellent. Now, as podiatrists, we have scalpels and we have forceps to be able to get the wound back to an acute point, an acute stage to bleeding point. But disrupting the biofilms in primary care is very important, and there are a lot of mechanical debridement products that you can use, and you'll have heard of. Taking a dressing off and putting another one back on perhaps isn't the best way without making sure that something has disrupted that biofilm to allow the wound to heal. And so we'll come now to basically, so that's what you take off a wound. What do we put on it? In the first case with the presenting ulcer, we obviously, as you know, we do no harm. The picture on the left, the dry, necrotic, gangrenous toe, were we to put anything moist on that at all, we could only do harm. It is best kept dry, with the best will in the world. No amount of fancy dressing on that is ever going to heal it up. It needs to be kept dry. The wound edges need to be kept dry, because allowing any moisture to get in those will more than likely cause infection, and the body of this person clearly hasn't got enough blood supply to be able to deal with that in any significant burden whatsoever. So we would keep it dry, a plain, simple dry dressing. As for the other wounds, it's all about moisture balance, as we know. So it's not allowing moisture to sit on the wound, not allowing the exudate to leak onto the perilesional skin. It's about getting the moisture away from the good skin, away from the wound itself, and just controlling it really. So they're a bit like house plants, aren't they? So maybe the one on the left is like a cactus, no water. Maybe other wounds need some moisture donation, and maybe the vast majority of wounds need perhaps moisture taking away from the lesion itself. What I would say here is, again, diabetes foot wounds are quite different than leg wounds. The dressing needs to be accommodated in some form of footwear, and quite often putting extra layers on that stop you having to change the dressing so frequently is not the best thing because it can cause pressure elsewhere. Under a first metatarsal, extra padding actually can increase the pressure on the area, particularly if an offloading boot has been made around a smaller dressing. Increasing the area of pressure with a pad or something to absorb exudate can actually make the wound get larger because of the increased load in that area. So it's quite important to think about the dressings in that form when you're putting them on feet. It's, like I say, a bit different to leg, arm, anywhere else on the body. So I'll draw to a close now just by saying that as practice nurses, we're ever grateful to you. You are the people who see the wounds more than anybody. You do a fantastic job in looking after them, even more than the person with the wound. You're probably more worried about it than they are, and no group of healthcare professionals is better placed to reduce amputations and improve outcomes in this devastating disease. So thank you to all of you, and I do hope that this has offered you a little bit of practical guidance in your day-to-day care of foot ulcers. Thank you, and please just type up any questions and I'll do my best to read and answer them now. Thank you.
Hello everybody, my name is Johnny and I'm a regional business manager. I cover Scotland and Ireland, and I'm going to talk to you this evening about Flaminal. I'll give a general overview of Flaminal, and I'll also touch on diabetic foot ulcers and also the diabetic foot ulcer pack as well. So let me just share my screen with you. So before I start, if you work in a podiatry setting, I would like you to think about the last time a person came in with a diabetic foot ulcer, and perhaps you were worried about infection or which dressings you could use on a person with diabetes. If you work in another clinical setting, just think about those wounds that are problematic, difficult to dress. They might be painful, sloughy, necrotic, or infected. So the Pass It On campaign, as Alison had mentioned, is a simple way of remembering what to do when a patient presents with a diabetic foot ulcer. So let me explain a little bit more. So as Alison says, the P stands for presentation. So the patient presents with a diabetic foot ulcer. We then move on to A for assessment. So consider ischemia, assess and document location, size and type and tissue type. Then we look at S for specialist. So we refer the patient to a high-risk foot service. Moving on, we go to S for solve. So we remove any obvious cause of ulceration. And then we pass it. So if there are any signs of infection, prescribe local antibiotics or antibiotics as per the local guidelines, sorry, and then you pass it on. So you dress the wound as per the pass it on guides. So the pass it on pathway is a simple chart that shows you how to dress the wound with diabetic foot ulcers. The timely use of topical antimicrobial agents to the wound bed is critical to prevent and manage infection locally, avoid unnecessary use of systemic antibiotics, and reduce the risk of antimicrobial resistance. The only ulcers that Flaminal is not indicated for are those which are dry and necrotic. These should be dressed with a simple dry dressing to prevent them becoming moist and infected. This simple chart, as you can see, shows you exactly what we can do when we're treating the patients. So we have put together diabetic foot ulcer rescue packs. These are available, they were previously requested in the last webinar. If anyone does want one, they are available through request or email. On the next screen, I have also put up some other details. In the packs, we've got some Flaminal literature. We've got the pass it on literature as well. We've got relevant case studies relating to diabetic feet and other wounds that are associated with diabetes. You can see we've got some pens and some nozzles there as well. If you would like a rescue pack, you may want to just take a screenshot of this, of the information that's on the screen at the moment. This is our contact details for the 3 other regional business managers within Flen, and we'd be more than happy to pass on your information to your local Flen representative in the area that's appropriate to yourselves. So if you're in the southwest, if you contact Andrew Welding. If you're in the southeast, if you contact Gerald. Scotland and Ireland is myself, and then there's Lewis for the northeast and the Midlands. What we can also do as well is we can arrange for remote education. Because Flaminal is so versatile, we can organise these remote sessions, educational sessions that can be tailored to your needs, and when time permits, we can also come out and do the education for your team as well. So moving on to Flaminal. First of all, what is Flaminal? So Flaminal is classed as an enzyme alginogel, and if we break that technical name down, we can see that Flaminal contains alginate. The alginate forms part of the absorbent gel, and then within the gel we have the unique enzyme system, and it's a unique enzyme system that gives Flaminal its antimicrobial activity. We have the 2 different compositions. We have Flaminal Hydro and Flaminal 40. Now the main difference between these 2 Flaminals is the alginate content that's contained within. So when you are considering which Flaminal to use, it's pure and simple that you just base it on exudate levels. So if exudate levels are high, we recommend using Flaminal 40, and if exudate levels are none to moderate, we recommend using Flaminal Hydro. So why use Flaminal on diabetic foot ulcers and other various wounds as well? There's 3 main areas that we look at. These are defend, protect and improve. So if we look at defend, first of all, Flaminal defends against infection and contamination. So Flaminal is a broad spectrum antimicrobial, and it's effective at killing a whole host of different bacteria, including MRSA, Pseudomonas, VRE, E. coli. But unlike other antimicrobials, Flaminal can be used almost in a prophylactic manner. So if wounds are at high risk of becoming contaminated, leading on to infection, you can use Flaminal as a safe and effective dressing to keep the wound nice and clean and free from infection. So with it being antimicrobial, the antimicrobial aspect is only one job of a number of jobs that Flaminal does. If we look at protecting the wound, Flaminal protects the granulation tissue and the wound edges. So there's no cytotoxicity associated with Flaminal. What I mean by that, and if we look at other dressings and antimicrobial guidelines, there's limited wear time where you have to follow and you may have to reconsider your dressing selection. If we were looking at silver, which is a very effective dressing at killing bacteria, antimicrobial guidelines dictate that you have a 2-week wear time, and then you have to check the wound, assess the wound, and if it's progressing to how you want it to progress, then you can continue for another 2 weeks. With Flaminal, it only targets the unhealthy cells, the cell walls of the bacteria, therefore protecting granulation tissue. So if you think about patients that you are treating, they may have comorbidities such as diabetes, they may be bariatric, overweight, they may have other underlying health issues, their diet, etc., which can all contribute to wound healing or delayed wound healing. Flaminal will also protect the wound edges as well. It protects the wound edges from maceration, so there's no risk of maceration when using Flaminal. In terms of improving the wound, Flaminal removes excess levels of exudate. So as we know that we have an optimal moisture level for wound healing. So if the wound is too dry, then the wound is not going to heal, and if the wound is too wet, then the wound is not going to heal either. So Flaminal gives you a step up and step down in exudate levels in order for you to get that optimal moisture level for wound healing. Flaminal also reduces bacterial bioburden and biofilms. So with chronic wounds, for an example, a high percentage of chronic wounds have a biofilm associated with them. Not all dressings will disrupt the biofilm or kill the bacteria within it, but Flaminal is different. Flaminal does disrupt the biofilm, it kills the bacteria within it, and it also prevents the reformation of the biofilm as well. It will also give you a nice clean wound bed, and you start to see a reduction in the wound size as well. So Flaminal prevents infection, it protects granulation tissue, and it facilitates wound closure. So as you can see in this diagram here, we're seeing a wound at different stages of the wound healing spectrum, from when injury occurs all the way through to wound closure. And it just highlights that Flaminal is a safe and effective dressing at any stage of wound healing. So you can dress that wound with confidence that Flaminal is going to be effective. So the difference between Flaminal Hydro and Flaminal 40, they offer real benefits for you and your patients. Flaminal is a flexible dressing, it controls infection, so it, like I said earlier, it is a really effective broad spectrum antimicrobial that kills infection. It's cost effective for a number of reasons. It's user friendly, so within the Diabetic Foot Ulcer pack as well, we send out nozzles or applicators for the tubes that can be inserted onto the top of the tube and just increase the ease of use of applying Flaminal to the wound. Flaminal protects the wound edges as well. It's effective with odour control, it maintains a moist wound environment, and it gently debrides the wound as well. Another good aspect of Flaminal, it's easy to apply and remove, which all helps with improving the quality of life with the patients that you're treating as well. It's versatile and kills bacteria. So the difference between Flaminal Hydro and Flaminal 40. So as you can see here, Flaminal Hydro is indicated for low to moderately exuding wounds. When you assess the wound and you assess the exudate levels and you deem that Flaminal Hydro is your suitable dressing, there is a number of suitable dressings that you can use Flaminal Hydro with. If we looked at a wound that has necrosis or eschar, and your objective was to debride that necrosis or eschar, the secondary dressing that we recommend for use is a film dressing. The reason being is the film dressing offers a moister wound environment to aid with autolytic debridement, therefore facilitating the process a lot faster. If you were to use foam dressing in the same scenario, it's not going to be detrimental, but it just will take a little bit longer. The foam dressing will do its job and absorb any fluid, exudate or moisture and just slow the process of autolytic debridement down a little bit. If you're choosing Flaminal Hydro for a moderately exuding wound, then we recommend using a foam dressing to handle the moderate levels of exudate. In terms of Flaminal 40, Flaminal 40 is indicated for moderate to highly exuding wounds. Therefore, we would recommend a secondary dressing to manage the high levels of exudate. Therefore, that would be a superabsorbent. When we look at the wear time of Flaminal, you can see from this table here that Flaminal 40 can stay in situ for up to 2 days. So if you are treating a wound with high levels of exudate, you may be treating that on a daily basis at the moment. We can then reduce the frequency of the dressing change to every other day. What you'd have to do as clinicians is you have to use your clinical judgment to ensure that Flaminal is in situ. That will see you through to the next dressing change. Flaminal's mode of action is it breaks down in the wound. So as long as Flaminal is in situ in the wound, it will continuously debride the wound, it will manage infection, it will balance the moisture in the wound, and it will also protect the wound edges as well. If we look at Flaminal Hydro, that can stay in situ for up to 4 days. So again, we can look at reducing the frequency of your dressing changes, which has benefits to the patient, improving quality of life, and also to you as healthcare professionals as well, because we appreciate that you're stretched more than ever with the current conditions with the pandemic going on at the moment. In terms of how much Flaminal to apply, we recommend a minimum thickness of 4 to 5 mil. So if you're in the UK, we give a rough guide of a pound coin thickness. But if exudate levels are increased, for example, if you're using Flaminal 40 on a highly exuding wound, just increase that minimum amount of Flaminal from 4 to 5 up to an increased amount. So ordering information. Flaminal in the UK is available via FP10, so prescription, and it's also available in acute settings via online ordering systems, so PCOS, ONPOS, for example, available through there. We have the ordering codes and catalogue numbers, and Flaminal comes in 2 different sizes. So what we have is we have a 5x15 in an aluminium tube, and we also have a 50-gram tube as well. Moving on to a brief summary of Flaminal. So Flaminal is versatile, it's dependable, and it's a very unique dressing as well. So it maintains, both Flaminal 40 and Flaminal Hydro maintain a moist wound environment. Now, a common misconception with Flaminal Hydro is that it's a hydrogel. Flaminal Hydro is not a hydrogel. It doesn't actively donate moisture to the wound, but rather creates a moist wound environment. Flaminal continuously debrides the wound, so via autolytic debridement. So if sharp debridement or mechanical debridement isn't appropriate or suitable, then Flaminal can debride necrosis and slough, eschar, autolytically, therefore assisting again improving patients' quality of life. Flaminal reduces bacteria and controls odour. So I said earlier on that Flaminal is a broad spectrum antimicrobial. It's a very unique antimicrobial, and it will kill a whole host of gram-positive and gram-negative bacteria. With it being so effective at killing bacteria, Flaminal is excellent for odour control. So if you do have any patients where odour is an issue, that may have an impact on their quality of life, and we can help with that aspect of dressing changing as well. If you work in other clinical settings, it may be an infected venous leg ulcer with Pseudomonas that may be causing the odour, or again, we could be looking at fungating malignant wounds as well. Flaminal minimises patient pain and discomfort. So it's a huge aspect of Flaminal where at Flen Health we always put the patient at the forefront of everything that we do, and if we can offer a dressing that minimises patient pain and discomfort, increases compliance and assists with wound healing, then it's a great choice for healthcare professionals out there. Flaminal is non-cytotoxic, so with this we have other antimicrobial dressings available to us to use in a clinical setting. If we looked at silver, for example, a very effective dressing at killing bacteria, but again, touching on that limited wear time, that you have 2 weeks before you have to review and potentially stop, or you may continue. There is no cytotoxic effect with Flaminal. It protects the granulation tissue, protecting the keratinocytes and fibroblasts, and it's safe to use from neonates all the way through to end of life. So Flaminal is also easy to apply in the most difficult areas. So if we look at the presentation that Alison gave us, it's very important that you have the option to choose a dressing that's going to be conformable to the patient's needs, that's going to be conformable with secondary dressings and also with footwear as well. Flaminal is very conformable, it's in a gel format, therefore again it's meeting the patient's needs when we're in a clinical setting. If we're not in a podiatry setting and you're working in treatment room or you're working in district nursing, it's easy to apply in difficult areas such as the perineum, sacral pressure ulcers, underneath aprons, skin folds and under breasts, and it's also very effective in narrow cavities as well, for example pilonidal sinuses. Completely removes the pain aspect of these particular dressing changes. I've touched on it a few times through the presentation, so Flaminal has no limit to the length of time it can be used. Again, just to re-emphasise, it doesn't follow typical antimicrobial guidelines. You can continue to use Flaminal as long as the wound is progressing in line with your healing objectives. Flaminal is cost effective for a number of reasons. We have cost effectiveness data and information that we can present to procurement and medicines management. But when we're looking at a patient setting, there is no waste associated with Flaminal. So when you open the tube of Flaminal and recap it, Flaminal self-sterilises, and as long as Flaminal is within its 2-year expiration date, Flaminal is completely safe to use. We also, in terms of cost effectiveness, you can use it indefinitely, and we can look at reducing the frequency of the dressing changes as well, freeing up your time as healthcare professionals. So that is Flaminal in a summary. That is it for me, but like I said, the slide that contained all the contact information for myself and my regional business management colleagues, please get in contact with us if you'd like any more information. And if you do have any questions, pop them in the question box and Alison and I will be happy to answer your questions, and I'll pop you back to Fiona now.
Thank you to Alison and Johnny for their presentations. They were very informative. I'm sure you would agree. You did a fantastic job, so thank you. And also thank you to the audience for your questions. It makes the event so much better when people do ask questions and get something out of it. So thank you very much. As I mentioned to you earlier, you will receive a certificate of attendance via the link that you were sent, and we will also send you a PDF of Alison's slides for your reference, so you don't need to worry about that. If you've requested a DFU pack, that will also be sent out or delivered via one of the business managers, so please again put it in the comments if you would like a pack. So once again, thank you very much for listening. Thank you, Alison and Johnny, for your presentations, and that's it from me. Enjoy the rest of your evening.
Flaminal 40 on a fungating lip and lower jaw. Is there any evidence to support its use this way? So with fungating malignant wounds, what we're doing is we're managing the symptoms of these fungating malignant wounds. So whether that may be odour, infection, slough, etc. That is what we're looking at to help manage these conditions. We do have a number of fungating malignant wound pathways that have been initiated within the UK, that if you want to pass your email address, we can send these out to you. But in terms of using it in that way, there is no problem of using Flaminal in that particular way. Okay, so we have another question, is what is the difference between blue and yellow? So the difference between the blue and yellow is the percentage of alginate that is contained within each composition. The yellow one, Flaminal 40, contains a higher percentage of alginate. The more alginate will give you more absorption, therefore Flaminal 40, the yellow one, is for wounds with high levels of exudate. In terms of the blue one, Flaminal Hydro still contains alginate, so there is still a level of absorption for your wounds, but it's indicated for lower levels of exudate. So from your dry necrotic wounds to your moderately exuded wounds. So when you are selecting the appropriate Flaminal to use, the first consideration that you have to give is the levels of exudate, and that is the main difference between the blue and the yellow. Everything else is very similar. Hope that answered your question. We will get packs sent out to everyone that we're seeing there. Can you put the contact for the Midlands and Shropshire area, please? As I couldn't read the contact properly. Absolutely. The contact for that is Lewis. If you are still here in the Midlands, if you want to put your email address, we'll get Lewis to get in contact with you. Okay, so here is a question. Can we use Flaminal on 4th degree burns that reach joint and bones? So in the UK we classify burns slightly differently. A 4th degree burn, I'm assuming that you're in reference to a full thickness burn. Flaminal is safe to use on full thickness burns, and it is safe to use all the way down to tendon and bone as well. There is no risk of dehydrating tendons, etc., and it's been used safely all the way down to bone as well. So the answer to that question is absolutely yes. Okay, so a question from Tracy: is Flaminal okay to use under compression dressings? So Tracy, when you are making reference to compression dressings, you mean compression bandaging? If that is the case, Flaminal is safe to use under compression. If you are relating to leg ulcers, for example, again, Flaminal is completely safe to use if you've got a venous leg ulcer under compression. Flaminal is completely safe for you to use. Yeah, so Tracy's saying yes there. So yeah, absolutely. We can provide, again, more information depending on where you're based in the country, Tracy. If you want to pass over your email address, etc., then we can put the relevant Flen representative in contact with you just to give you a little bit more information about Flaminal and its use under leg ulcers. Similar to the Pass It On initiative, we have a leg ulcer initiative as well, with specific case studies and educational material that will help you in that area as well.